Hello, everybody. This is your human body anatomy and physiology lecture. I'm not going to go over every single slide in your PowerPoints. I'm going to kind of hit the kind of more focused areas for you guys, and I'm also going to break down these lectures in hopefully about 20, maybe 30-minute increments for you guys based on the actual body system that we are talking about. We will be doing a review as we go into medical emergencies for each system of the actual anatomy and physiology before we actually get into the disease pathologies that you guys need to know for this class as far as being a licensed ENT basic. This is definitely not an official anatomy and physiology course. Some of you guys might have taken anatomy and physiology. This is basically kind of focus for EMS providers. Okay, so some basic definitions. Anatomy refers to the actual body structure and to position in which the structure might be, that the body might be actually positioned, and the underlying organs that are underneath the skin. Physiology refers to the actual function that the body performs for us, or that the actual system that we're talking about performs with us. And it is crucial that you guys do know what is normal as far as human anatomy and physiology, so that it does kind of make it easier for you guys to find the abnormal. Because remember, in EMS, we are the best detectors, or detectives, I guess is the best way to put it, in order to find out what's going on for our patient. When we are talking about directional terms, this is a way for us to basically, these serves as a guide to the structures that lie beneath our skin, so that we can kind of do a best guess judgment on what may be injured in our patient if they have sustained an injury. Think of this as kind of our x-ray vision to be able to try to attempt to figure out what has been injured underneath the patient's skin. When we talk about normal anatomic position, the normal anatomic position of the human body is if I am facing you, I'm standing up straight, I'm facing you guys, and I have my palms facing forward. So my thumbs are pointing away or out towards my body, okay? Everything that these directional terms are based off is if I was in that position, okay? And this is a hard concept for you guys, because you guys are going to be seeing patients, and you guys got to remember that your left is their right, and your right is their left when you're looking at them. Hopefully these directional terms will help you guys out with that. So I'm going to spend a little bit of time on this slide here. When I'm talking about midline, this is anything going towards the center of the actual body. So if you can picture, actually, if you would kind of put a string through your head and kind of follow it down the inside of your spine, and kind of cut the body into right and left, that is what the midline or the middle of the body is. When we're talking about anterior, it's also known as the ventral view. This is just the front half of the body. So if you were to take a saw and saw my head right down the middle of my ears, all the way down my body to my shoulders, this was you sawing me in half, basically from front and back. Okay, anterior is the front. Posterior, also known as dorsal, think of it as like the dorsal fin of a dolphin, is on the back of my body. When I'm talking about movement away from my body, that means I'm moving in a lateral direction. Okay, it could be a left lateral or a right lateral, but either way, I am moving away from my midline. So an example of this would be my right eye is lateral to my nose. My right ear is lateral to my right eye. We're kind of moving out from the middle of the body, going to the sides of our body. Medial is different from midline. Medial is actually close to midline. So this means that it's actually moving in from a lateral which is on the outside or away from the midline, and it's moving in towards the middle. So my nose is medial compared to my eyes. My sternum is medial compared to my nipples. Okay, superior is above. Okay, anything that's above or closer to the head. So my knee is superior to my ankle. My elbow is superior to my wrists. Inferior is just the exact opposite. My wrists are inferior to my elbow, and my ankles are inferior to my knee. Proximal and distal. Proximal means that it's actually closer to my trunk. And when we talk about the trunk, or what I'm going to refer to as the core of the body, basically in EMS, we teach you guys the core is actually from the top of your head, basically down to your knees, not including the arms. Okay, so it's just the actual core of your body. We hold a lot of vital organs in these areas, definitely areas that we do not want to get injured, specifically when it comes to traumatic events. But proximal is closer to the trunk, so let's stay on this one for a little bit. My shoulder is more proximal to my trunk than my elbow is. My elbow is more proximal to my trunk than my wrist is. Distal means it's further away from my trunk, so my knee is distal to my hips, and my ankle is distal to my knee. This here is a great visual of what we just kind of talked about as far as directional terms. You guys can see anterior and posterior. Anterior is the front, posterior is in the back. Superior and inferior, you can actually get a visual of the midline, which is the yellow arrow going right through the middle of the body. Medial and lateral. Medial is closer to midline, lateral is away. And then proximal and distal, we're closer to the trunk with proximal, and we're further away from the trunk going distally. Okay, as far as how your actual positions of your patients, or possible positions of your patients, when we're talking about somebody actually lying prone, that means that they are lying on their stomach face down. This is definitely a position that we do not like in EMS. We are unable to protect the airway at this point. It's harder for people to breathe, whether you think so or not, in this position. We definitely want to be able to roll them on their back if at all possible. When we do roll this patient on their back, it's known as supine. Supine is where you're laying completely flat on your back on the ground. This is the kind of the optimal position that we would like our patients in, if they are unresponsive. Fowler's actually has a couple of different terms. We have a high Fowler's, and then we have a semi-Fowler's position. High Fowler's is basically you guys sitting up in a proper seating, right? So you guys are sitting up in about a 90-degree angle. When we talk about semi-Fowler's, which is a position that we like to keep our patients in for EMS, specifically on our gurneys, when we have them in the back of the ambulance, semi-Fowler's is anywhere between a 45 and a 30-degree angle. We try not to keep our patients flat, and we're going to talk about that more when we actually get into the disease processes themselves. But Fowler's is a very common position for us in EMS. And then below the Fowler there, you see the recovery position. The recovery position is something that we use for patients that are unresponsive, or possibly if we have multiple patients on scene with multiple injuries when we're doing our triage, and we're going to talk about triage later on this semester. But this is a way to actually protect the airway for us so that we can walk away from our patient if they are unresponsive, and then come back to them later on, specifically in a mass casualty incident scenario where we have more patients than actual providers. We have two different types of recovery position, and it actually does have a different definition or different term for it. They could be either the right side or left side, but we call it either right lateral recumbent or left lateral recumbent. Either way, they're still known as the recovery position. And as you can see, we kind of have the person's leg kind of bent at the knee. This lady's laying on her left side. She has her leg bent at the right knee. She has her head resting on her arm that is on the ground, and then technically she should have that right arm kind of holding or holding on to her shoulder. And what this does is it actually elevates the head off the ground and creates a stable, somewhat stable airway for us, so that if this patient does vomit, they're not going to drown in their own vomit, right? They got a little bit of space there to kind of protect them from the actual fluids when it comes down to it, so that they don't aspirate on their own or choke on their own vomit. Again, we like to do this with any patient that is in that we have that's unresponsive, and we're going to talk about that specifically a little later on once we get into those disease processes. Okay, a couple more movement terms. I think the picture is the best way to show you guys these. We all know how to flex. We all know how to show the guns off. So that's flexion. When we lower our arm back down, that is now extension, okay? Where you guys get mixed up is with abduction and adduction. So abduction is basically moving away from the body. So if you had your hands on your side, if you had your arms on the side of your body, and you lift your arms up, kind of like flying through the air or pretending like you're an airplane, that is abduction. Okay? When I lower my arms back down to my side, that is adduction. So the way I remember this is like when you lower your arms down to your side, you're actually adding to your body. Okay? That's the best way for you guys, or at least that's the way that I remember it. Okay, the actual core of our body, or the trunk of our body, is actually made up of 4 different body cavities. The cranial and spinal is all one cavity. They kind of share it. I want you guys thinking from here on out as the spinal cord as the tail of the brain. And it's all contained in one body cavity. We have our thoracic cavity, which is basically the just our chest, our upper half of our torso. The thoracic cavity has all of our great vessels and our vital organs, what we consider our vital organs, such as our heart and our lungs. And by great vessels, I mean the aorta and the vena, superior and inferior vena cava, and just a whole bunch of arteries branching off the actual aorta itself. And we're going to talk about the mediastinum here when we, specifically when we get to trauma and cardiac. You guys see on this little picture on the right here, that little orange kind of sad face, I guess is the best way to put it in the picture. That's your diaphragm. The diaphragm, which is the main muscle of breathing, we're going to talk about that here in a sec as well. But the diaphragm is what separates your thoracic from abdominal cavity. Please make sure you guys know that for the exam. The abdominal cavity, there's not much protection there, but that is a cavity by itself. The abdominal cavity basically extends from the bottom half of the diaphragm down to the pelvic cavity, which is the last of the body system, or of the body cavities. And I put this up here because you guys need to know that we could bleed internally, heavily bleed internally in all 4 of these cavities. And we're going to talk about that more specifically when we get into trauma. Okay, so let's get into our first system here. This is the musculoskeletal system. We're going to talk about, not really focus on a lot of the muscles. You guys really don't need to know all the muscle groups. But we are going to talk about certain bones that are pretty important to us. We're going to have a little small discussion about joints and connective tissue as well. But really, just so you guys are aware and probably already know from just general knowledge that the musculoskeletal system really provides protection for all of our organs for us. It helps us with movement, and it helps to actually keep the shape of our body. So us in EMS actually breaks down our skeleton into 2 different skeleton structures. We have the axial skeleton and the appendicular skeleton. We're going to start with the axial skeleton. This is basically our core. This is the foundation to which the arms and legs are attached to. It includes our thorax, it includes our spinal column, part of our pelvic cavity, and our skull. So with the skull, your cranium is made up of 4 different bones, okay? The actual skull itself, we have your frontal bone, which is your forehead, your parietal bone, which is basically the top of your head, your temporal bones, which protects some pretty important arteries for our brain. And then we have our occipital lobe, or occipital portion of our skull, which is the back of our head. The face made up of about 14 different bones. You guys don't need to know all 14 of them. I do want you guys focusing on the zygomatic bone, which you guys can see in this picture here. That's basically your cheekbone, and the zygomatic bone is responsible for keeping your eye in your socket. You guys are definitely going to run calls where that cheekbone has been broken due to some kind of traumatic event, and the possibility of their eye falling out of their socket is very high. We'll talk about that more when we get into trauma. But know the zygomatic bone. Make sure you guys know that the lower jaw is known as the mandible. That can give us a lot of problems if that is broken. And then the maxilla is actually the main face bone that makes up the majority of your actual face and your facial structures. And that is where your top teeth actually connect to. On the picture on the right, you guys see that big hole in the base of the skull. That is known as the foramen magnum. Please make sure you guys know that. The foramen magnum is the only hole in our skull. And what that does is it gives a way for the actual spinal cord to enter the spinal cavity. So that's protected by the vertebrae. Basically, we're going to talk about the foramen magnum, and when we come to trauma with what we call intracranial pressure, and unfortunately for some people that is the only way the brain can swell, and we're going to talk about that later on, but it is a giant hole, and that's really what it means. Foramen magnum means big hole, and that is the hole that the brain uses to extend its tail or the spinal cord into the spinal cavity. So continuing with the exoskeleton, we've already covered the skull. We're going down to the spinal column now. You have 33 different vertebrae. They are separate bones that start at the basically the base of the skull all the way down to your tailbone. It's divided into 5 sections. You got your cervical, thoracic, lumbar, sacrum, and coccyx. Your cervical spine is your neck. It's basically composed of 7 different vertebrae. Your thoracic is basically starts kind of where your shoulders begin, and it goes down to right about the base of your ribs on the back, if you guys can picture that. That has 12 vertebrae. Your lumbar from the base of your ribs all the way down to your top of your pelvis. That has 5 vertebrae. Your sacrum actually, your sacrum and your coccyx is actually composed of, or both combined to make your tailbone. The sacrum is actually 5 different vertebrae that are fused together, and your coccyx has 4 different vertebrae that are fused together. The best way I remember this is cervical, thoracic, and lumbar. We have 7, 12, and 5. I remember as breakfast, lunch, and dinner. And then just remember that the sacrum and coccyx have 5 and 4 that are all fused together to form your tailbone. Okay, moving into the thorax, or your chest, basically. This is formed by 12 different vertebrae, and you have 12 pairs of ribs. Yes, this is not a coincidence. This is how the body is developed. The ribs 1 through 7 are actually directly connected to the sternum. Ribs 8 through 12 are actually connected to rib 7 through cartilaginous structures. Okay, you guys can see on that picture there. We do have the sternum, which is actually broken down into 3 different sections. We have the manubrium, which is where your 2 collarbones meet, both right and left collarbones. That is the start of what we call the breastplate, also known as the sternum. Then we have the body of the sternum, Okay, the body of the sternum is very important to us because this is where we are performing CPR on our patients. And then we have the xiphoid process at the very end there. We used to do CPR on the xiphoid process. We thought back in the days that that was beneficial to our patient. However, if we are doing CPR and our hands are placed too low to where we are doing CPR on the xiphoid process, we can actually break that off and pierce the heart. And that's not good, right? So we want to make sure that our hands are nice and high on the chest when we're doing CPR, basically making sure that the bottom of our hand is in line with the patient's nipples as best as possible, depending on the patient, obviously. But this cavity definitely contains all of our vital organs, all of our great vessels. It actually contains part of our trachea, part of our esophagus, our lungs, and our heart. Definitely an area we do not want to have injured. Okay, moving into the appendicular skeleton. This is basically your arms and legs and all the connective joints associated with those, and your pelvis. Okay, so joints are basically wherever bones come into contact with one another. And it consists of the ends of the bones and the connecting and supporting tissues that hold those bones in place, right? It's got a whole bunch of tendons. It's got a whole bunch of ligaments in order to keep the bone structure from slipping past each other. We basically have two different types of joints. We have a ball and socket joint, or at least two joints that I'm holding you guys to at the EMT basic level. We have a ball and socket joint, which actually allows for rotation and bending, and we have a hinge joint, which actually only allows for flexion and extension. And you guys can see this little picture here for you guys on the two different styles. The ball and socket joint is your best example is your shoulder. You guys can spin your arm around in a kind of a 360, and you guys can rotate it from left to right as well and flex. And bend it, lift it, whatever you guys need to do. As far as the hinge joint, the best one is the knee or the elbow. All we can do is flex and extend with those ones. When we're talking about the upper extremity, it's actually three different bones that are coming together, at least where the start of it is, okay? The clavicle, your scapula or your shoulder blade, and the actual humerus, which is the upper bone of the arm, which extends from the shoulder down to the elbow. The humerus is considered a long bone, and the humerus, if broken, could be technically considered a life threat to our patients. We do have a lot of vasculature that surrounds the humerus. We have some pretty major muscles with your delts and your lats and your biceps in that area that can cause some problems for us. But you guys can see kind of how this is positioned in your body based on the graphic that I have here. But yes, we are going to talk about breaks to long bones later on this semester, specifically when we get into trauma, and the humerus could technically be considered a life threat. We have the humerus. When we're talking about the arm itself, the humerus is actually the supporting bone for our arm. Without the humerus, we really can't do much. Our arm is just going to sit there and dangle. The humerus is a very important bone for us, and that's why we do consider it a life threat, specifically if it is broken. Like I said before, it's got a lot of vasculature around it. It's got nerve endings around there. It's if it breaks and that bone happens to not be a clean break, or it's like at an angle and it creates a sharp bony end to that bone, that sharp bony end can be very destructive to the inside of our body. Later on the semester, you guys are going to learn how to splint both bones and joints. They are different the way we splint them. You guys already have your videos on that stuff on your lab shell. You guys can start watching those if you want. But we will train you guys on how to splint that and reassess your patient accordingly. Your forearm actually has two different bones known as the radius and ulna. So as you can see, that arm is in anatomical position. Okay, that thumb is pointing out. With the thumb pointing out, as you're looking at it, the bone that runs along the same side of the arm as your thumb is known as the radius. Okay, and you guys can remember that because that's where we actually feel for a radial pulse, right at the wrist, just below the thumb, where like kind of the arm meets the wrist. we're pushing that artery up against the radius in order to feel the pulse. Okay, the ulna is on the inside or the medial aspect of the arm that basically creates your elbow. That is your with the ulna. The head of the ulna is the actual little knob that you guys feel that creates your elbow. You guys can notice that little space in between the two bones. Again, that's where a lot of vessels are held for us. Some of our major vessels, specifically our radial artery, the majority of our radial artery is held in that little space, along with some nerve bundles as well. All right, finishing up the upper extremity, we stop at the hand. The wrist, when we're talking about the wrist is where the radius and the ulna come together. And it's met by what's called carpals. Okay, so we're going to talk about tarsals in the foot, but we have carpals in our hands. Okay, and the carpals are just a bunch of bones that are kind of fused together in a way that kind of gives us support to our palm. Our palm is made up of the metacarpals, as you guys can see in the picture here, and then from basically our palm up, or our digits, also known as phalanges. The pelvis is a very important structure for us. This is the reason why we were able to stand on our hind legs a long time ago. This is a very bony prominence. It has lots of vasculature around there. It has lots of nerve endings. It holds some pretty important stuff in place for us, specifically all of our respiratory and our urinary system for us. The pelvis itself is actually three different bones that are, I don't want to say fused together, but we identify them as three different bones. We actually have the ilium, which you guys can see on the top, which is the meaty part of the actual bone. The iliac crest there is part of the ilium. The iliac crest is what gives us our hips. Those are the bones that we can see. That gives you guys all your sexy curves, right, when you're out on the beach. And then we have the ischium, which is actually there to kind of create your butt cheeks. It's what we sit on, right? It's the part of the actual pelvis that we actually sit on. And then we have the pubic bones, right, which are left and right pubic bones, and those come together at a structure known as the symphysis pubis, or the pubis symphysis, however you guys want to put it. It's flip-flopped in the anatomy books both ways. We also have the acetabellum. You guys can see the acetabellum on the left-hand side of that picture there. This is the insertion point for the head of the femur. Okay, this is actually what science believes to be a mistake for us when we actually decided to stand up. When we stand up on our hind legs, we don't have a good connection between our femur and our pelvis. That's why we do get, as we get older, we are more susceptible to injuries, specifically if we have disease processes such as osteoporosis or osteoarthritis, something like that, some kind of bone disease like a bone cancer or something. But as you guys can see, we do have some major vessels running through there. We have the descending aorta. Okay, it branches off basically right at your tailbone to go down into the left and right femoral arteries. And we also have the inferior vena cava, which is bringing blood back to our hearts. Okay, it is a big vein, and yes, you guys can sever the inferior vena cava, and it will act like an arterial bleed. Okay, and we're going to talk about that more later on. But the symphysis pubis there, the symphysis pubis is a very important structure for us. It is more prominent in females than males. In fact, the whole pelvic cavity is more prominent in females than it is with males. And the reason for that is because this is where childbirth occurs. If we do not have a pelvis, a good functioning pelvis, a good stable functioning pelvis, we are unable to give birth. The female's tailbone is wider, and it's also at more of a curve in order to help with pushing that baby out. Their symphysis pubis has a lot more play in it to allow their hips to spread during the birthing process. Females, your symphysis pubis is basically a very spongy cartilaginous structure until you guys hit menopause. After that, it does start to calcify. Gentlemen, your symphysis pubis basically starts to calcify between the ages of 25 and 28. Again, this is a very heavily vasculature area. We can technically hold every drop of blood in our pelvic cavity and not show any signs of distension or any kind of bloating in our pelvic cavity with all of our blood in it. Obviously, you're going to see signs of death before that, but we can hold every drop of blood in our pelvic cavity without showing any signs or symptoms of it. When we break the symphysis pubis, and you guys will run this call, it's called the butterfly effect. We have filleted open the pelvis, which means that our legs are not supported. Your patient's not going to be able to bear weight, but man, they could do the splits like nobody's business if you guys break the symphysis pubis. And you guys will run this call. This is usually due to traumatic events, specifically falls from long height, shallow water diving accidents. And for all you motorcyclists out there, specifically if you rear end a car and your body keeps moving forward, I've seen actually a couple of symphysis pubis injuries, and man, it does not look pleasant. We'll talk about that more when we get to trauma. Okay, jumping ahead to the lower extremity, I want you guys to kind of take a look at this picture for me. You guys can see the actual right side of the pelvic cavity there, the actual pelvic bone itself. You guys can see the acetabellum and how the actual femur joins at the hip. It is just basically that little femoral head that's kind of supporting the whole weight of your body. Now, that being said, there is a lot of tendons and ligaments around that area in order to keep that structure in place. However, it is very easy to injure. And when we injure that area, specifically the femur itself, which is the long bone or your thigh bone in your body, the femur is a life threat. Okay, guys? If we have had enough force to break the femur, we have got to assume that there is multiple underlying injuries. It is not easy to break a femur. Even if somebody has history of osteoporosis or osteoarthritis or some kind of like bone cancer or some other kind of debilitating disease, it is very hard to break the femur. And the problem with the femur is the femoral artery runs literally right on top of the bone. So that if we do not have a clean break in the femur and we actually create a sharp bony prominence when that bone breaks, that bone can technically pierce the femoral artery, and we have a whole other situation on our hands. Okay, we're going to teach you guys how to use traction splints. There's two different types of traction splints, known as the Hare and the Sager traction splint. They're both used within the all EMS systems. It just depends on whichever flavor the EMS system likes. Guys, this might be the first and only time you guys put your hands on a traction splint. It is very rare to run a femur. In fact, I didn't run a femur. I didn't run my first true known femur where I actually used the traction splint until about 10 years into my career. So it's definitely a skill that needs to be practiced. It's definitely a skill where we can cause a lot more injury to our patients, but we'll talk about that more when you guys actually look at the skill video in lab and we discuss it in lab as well. The knee connects your upper leg to your lower leg, so the knee is the connecting joint that kind of connects the femur to your tibia and fibula, which is your lower leg bones. The knee itself has a numerous amount of nerve endings around it. It has a lot of ligaments. You guys, if you guys have ever maybe torn one of your ligaments, you guys know how long it can actually take to rehab that. It's very prone to injury. It's really the one of the toughest joints in your body that really gets used and abused, and nobody really takes care of their knees. And And we need to make sure, specifically with us in EMS, that we're using proper lifting techniques and whatnot, because I know a lot of really good medics that have had career-ending injuries due to their knee and their back, but mostly their knee. Just be careful when you guys are lifting heavy patients and make sure you're using the proper way to lift. When we're talking about the lower leg, we're talking about the tibia and fibula. All right, so the tibia is actually your shin bone. Okay, that's the actual bone of the leg that we can feel. This bone is going to become much more important to you guys when you guys move up to intermediate and paramedic. We do something called an intraosseous infusion, which is basically an IV that we drill straight into the bone for emergency medicine. You guys will get trained on how to use that, whether you're going to intermediate or paramedic. And we are actually drilling that bone into the shin bone. We can also drill it into the humerus, which is the upper arm bone, but most likely you guys will be starting IOs or interosseous infusions in the tibia. And then the fibula is on the lateral side of the leg. It's on the outside of the leg. It is a very small bone. It's there to basically help with the attach the ligaments and tendons around the knee. And really, the way we see it in EMS is that if we have enough force to break the tibia, more than likely we have also broken the fibula. The fibula bone in most people is very hard to feel. We can somewhat feel it in little ones, right, like pre-adolescent children. But it is hard to feel for the fibula, and we just assume that if the tibia gets broken, the fibula is also broken, so we don't want our patient bearing weight on that. Okay, moving down to the ankle and the actual foot. The ankle, just like the wrist, the ankle is where the tibia and fibula meet, and it is met by what we call tarsals with the T. Again, those tarsals are a bunch of fused bones kind of put together in order to help the support between the actual lower leg and the ankle itself. From there, we go to the metatarsals, which is actually the kind of the arc of your foot. So that creates the arc of your foot, or what we consider like the palm of the foot, right? And then your toes are also known as phalanges. Your heel is known as the calcaneus. It is actually one of the most bruised bones in our body. I don't know if you guys know that. If you guys have ever bruised your heel, I'm sure you guys understand that is not a very comfortable bruise. It can be very debilitating to us, even though it is just a bruise to a bone. Lots of very tight tendons and ligaments in this area. Your wrist is the supporting structure. I'm sorry, your ankle is the supporting structure for the whole body. It is very, very weight bearing. We do a lot of damage to our ankles, right? And the littlest kind of sprain or strain can cause some serious pain for us. We also have the Achilles tendon, and the Achilles tendon is the basically what holds our foot in place, guys. It holds our calcaneus, or the heel of our foot, to the rest of our body in order for us to be able to move and our foot up and down. Basically, the Achilles heel is the Achilles tendon is the only reason why we are able to walk and run. Okay, when we're moving into our actual muscle system, or our muscles, I'm not going to spend too much time on this, guys. You guys can read over the slides that I skipped ahead with. But basically, we can't do much for a muscle tear, right? It's one of those situations where we would love to be able to tell our patients, hey, just rub some dirt on it, it'll go away. But unfortunately, you guys got to remember that in EMS, it is not our emergency, okay? If the patient wants to go to the hospital because they pull their calf muscle, at this point in our EMS careers or in our EMS systems, we are not allowed to refuse transport to anybody, okay? So, again, we can, you guys have all heard of like rice, right? Rest, ice, compression, elevation, for pulled muscles or for sprained ankles and whatnot. But there is some anatomy that we need to kind of get into with the muscles. All right, I'm not going to have you guys know the muscle groups, but there are some different types of muscles out there that are pretty important to us. Okay, or at least important to know in our knowledge. When we're talking about skeletal muscle, is the majority of the muscle that we have. It is completely 100% voluntary. You guys are able to control this. You guys can get up and walk when you want to. You guys can pick your boogers out of your nose because of your voluntary muscles. You guys can do flips or cartwheels or whatever it is you guys do, right? When we're talking about smooth muscles are actually found in our digestive system and in the inside of our veins and arteries. We have no control over these whatsoever. This is all based on the brain, and the brain tells us if we need to constrict or dilate our vessels, which we'll talk more about in the nervous system, or if we just ate that delicious Wendy's Baconator with large fries dipped in the chocolate frosty, right? Which is like the best ever. But anyways, it helps us through a process called peristalsis. And peristalsis is technically the process of digesting food. The peristalsis, to make it easy, it's where you eat the food and you guys create poop. And it's all because of the involuntary smooth muscles in our body that does that for us. And then we have cardiac muscles. And cardiac muscles are very unique, and we're going to talk about that specifically when we get into the cardiac section of the anatomy and physiology. Okay, guys, we're jumping into the respiratory system. This is one of what we call the big three systems. The big three contains the respiratory, the cardiac, and the neuro. These are the most important systems that you guys are going to learn about in medicine. Crucial to the body. When we're talking about the respiratory system as a whole, it's basically how the body processes oxygen. Okay, your respiratory system is responsible for providing oxygen to all the cells in order to create energy, and it removes CO2 from our blood. And for all you chemistry geeks out there, I'm going to make you upset, but I want you guys to think of something right now. CO2 is no longer a gas. Okay, I'm going to say that again. CO2 is no longer a gas. CO2 is now considered an acid in our body. Okay, so anytime I say the word CO2, I want you guys thinking acid as well. And our body does not like acid whatsoever. Okay, when we're talking about the respiratory system, and I'm not going to spend too much time on the anatomy, right? I'm going to get more into it when we actually start talking about respiratory emergencies. But when we're actually talking about the respiratory system in general, it's a very fragile system. A lot of things can go wrong with it. It is very sensitive to toxins and allergens and infections as well. All right. When we're talking about the respiratory system, you guys can see on this graphic here. This is a great graphic, and you guys basically need to know everything on this slide. Okay. This is extremely important to us. The respiratory system with EMS is our bread and butter. This is the most common call, technically, that we do run in EMS is a respiratory emergency. And it's a serious call, right? And we're going to talk more about that when we get into respiratory emergencies. So the structures that we see here, okay, when we're talking about our upper airway, whether you guys are nose or mouth breathers, hopefully you guys are nose breathers, but our air passes through our nostrils, or what we call nares. We have a right and a left nair. That goes into the structure called the nasal pharynx. And the nasal pharynx is all connected with our sinus cavities and everything like that. And really our nasal pharynx is there to help filter the air that we breathe in. Inside your nose, you guys all have nose hairs. Even you ladies, you guys all have nose hair, right? Some have more pronounced nose hairs than others. But basically, that hair is there to pull all the dust and the allergens or toxins, and kind of filter out that air so that all that toxins or dust or whatever dander doesn't reach our lungs. The nasal pharynx actually connects to the oral pharynx in the back of the throat, and the nasal pharynx and the oral pharynx make up what's called the pharynx in general. Okay, we do have a mouth, that's our opening to our digestive system. We have a tongue, which is actually a huge muscle. It's much bigger than you guys think it is, especially if you guys eat lingua, right? Cow tongue. Those suckers are huge, right? Yours is not much smaller, to be honest with you, okay? And please remember that the tongue is the number one airway obstructor. The tongue is the number one occluder of the airway, okay? All you guys and gals that are out there and you guys snore in the middle of the night, you guys don't have to admit it, right? But most of us do snore during the night, and if it's really bad, you are technically not breathing correctly when you're sleeping, and that can cause a whole bunch of health problems for us as well. I say this to all my classes: if you guys are legitimate snorers, you guys probably should go get a sleep study. It'll change your life. Yeah, you do have to wear a little machine when you go to bed, or what we call a CPAP mask. We're going to talk about CPAP later on in lab, but it'll change your life. I know guys that have cured their diabetes. I know people that have lowered their blood pressure and have stopped taking their blood pressure medicines just because they're able to breathe in the middle of the night due to good sleep. We also have this structure called the epiglottis, and the epiglottis is there. It's kind of like the gatekeeper to our trachea. Every time that you guys eat, you have digestive enzymes in your mouth that starts to break down the food. When we break down that food, we call it a bolus of food. And it's basically the ball of food that you guys kind of put together while you guys are chewing in order to swallow. Every time that you guys swallow, believe it or not, or subconsciously, every time you swallow, your tongue technically moves forward in your mouth in order to make way for that bolus to go down your esophagus. Well, the epiglottis is in charge of actually covering the opening of the trachea and to give the food no other place to go but down the esophagus. So when your tongue moves forward, it actually pulls on that epiglottis to cover the hole of the trachea so that your food has no other way to go but down the esophagus. If we have problems with our epiglottis, and we're going to talk about that in our respiratory emergencies, we might not be able to cover our trachea when we swallow, and we do have a risk of choking. Obviously, if you guys know, if you guys get food stuck in your windpipe, also known as your trachea, you guys are now choking. And then it goes down to the larynx. The larynx is actually your vocal cords. It contains your vocal cords. It's the structure that separates the upper from the lower airway. Please make sure you guys know that. The larynx is the structure. Your vocal cords is what separates the upper from the lower airway. The larynx then moves into the opening of the trachea. The trachea is also known as your windpipe. The trachea could be anywhere between about 3.5 to 6 inches in length, depending on the size of your patient and the age of your patient. The trachea is held open by cartilaginous structures, and it goes all the way down where it branches off into the right and main stem bronchi, which is the entrance of your lungs. Also, the actual division of the trachea into the right and main bronchi at the division is known as the carina. The carina actually stimulates a cough reflex in us, and it is the last-ditch effort of keeping toxins or allergens or dander or whatever it is that our nares didn't necessarily fix for us, but it can produce a cough for us. Once the trachea branches off into the bronchi start getting smaller and smaller and smaller as they enter the lungs, going all the way down, almost microscopic. The bronchi will end at or the bronchi, as they get smaller, are known as the bronchioles, and the bronchioles actually go down into the alveoli. That picture in the lower right there is what the alveoles look like. They look like these little grape-like structures. They're surrounded by capillaries and capillary beds. That is where the process of respiration, the process of respiration occurs. All right. The process of respiration, the definition of respiration is basically just gas exchange. This is where oxygen is unloaded into our system and CO2 is offloaded from our system in order for us to breathe out. All right. You guys can see the lung tissue there. All right, so we're going to talk about the lungs separately in the slides coming up. And then we have the diaphragm. You guys can see the diaphragm there. The diaphragm is the main muscle of breathing, and we'll talk about the diaphragm as well later on. I would strongly suggest to all of you guys that you read this section in your book as far as respiratory anatomy, and make sure that you guys understand or be able to track an oxygen molecule all the way from outside the body all the way down to the alveoli and what structure it actually passes. Okay, guys, I skipped ahead a couple slides, but you guys can read up on those. I want to get into the lungs. You guys have two lungs. They're actually held in place by the trachea, a whole bunch of arteries and veins, and what's called pulmonary ligaments. Okay, the lungs are extremely important to us. They are very fragile. They're very sensitive. We can have a lot of disease processes go wrong with them. However, when you guys get into respiratory treatments, the treatment is technically pretty similar for all the disease processes, but I'll talk about that when we actually get into the emergencies. So your lungs are divided into what's called lobes. Your right lung has 3 different lobes, and your left lung has 2 different lobes. The left lung has 2 different lobes because it had to make room for the heart. So the heart kind of takes up where the 3rd lobe of the left lung would have actually been. So if you guys get a question on how many lobes do the lungs have total, the total amount is 5. 3 on the right, 2 on the left. Okay. The lungs is where gas exchange occurs, and we're going to talk a little bit more about the lungs here in a sec. So found in the lobes of the lungs are the bronchi, which is, remember, the actual branching off of the trachea into the right and left main stem bronchi. Those bronchi get smaller and smaller, which are known as bronchioles, and those bronchioles lead all the way down to the alveoli sacs. This allows for the gas exchange, or the process known as respiration. The pleura is actually the lining of the lungs, and the pleura is there to create a lubricant, also known as surfactant, but the lubricant is so that our lungs don't actually stick to the insides of our chest when they actually fully inflate. Again, we'll talk about disease processes and respiratory, where the pleura can actually get infected, and the lungs do actually kind of start sticking. It's very painful to breathe for our patients. We'll talk about that more when we get into respiratory emergencies. Which now brings us to probably the most important slide in the respiratory lecture. The respiratory works in conjunction with the cardiovascular or cardiac system in our body. There are a principle called the Fick principles, Ficks principles, that was developed by a physician many, many years ago. And it kind of relates to how the respiratory and cardiac systems work together. The Fick principle is composed of 4 different elements: ventilation, respiration, circulation, and perfusion. And for respiratory, we're just going to talk about ventilation and respiration, Fick 1 and Fick 2. When we talk about Fick 1, also known as ventilation, the definition of ventilation is basically the mechanical movement of air in and out of my lungs. That's all it means, okay? However, respiration is actually being able to get that air all the way down to my alveolar sacs and actually have the gas exchange occur, okay? This is a process of diffusion and pressure gradients, right? We have these big old bronchi, which is basically the extension of our trachea leading into our lungs. Those bronchi get smaller and smaller, known as bronchioles, which goes down to alveoli, and it actually pressurizes that air for us to help with gas exchange through diffusion. Remember that diffusion is from areas of higher concentration to lower concentration. Movement from areas of higher concentration to lower concentration. So, the blood in your lungs, right, when it's returned through our heart and put into our lungs to get oxygenated, it's filled with CO2. Okay, so when you guys breathe in that oxygen, the CO2 and O2, the carbon dioxide and the oxygen, basically just switch places so that we can blow out the acid or the CO2 from our body, and we intake the oxygen in order to get all of our cells the energy that it needs. As far as inspiration and exhalation, inspiration is actually when the diaphragm contracts. So picture you guys, kind of follow your rib cage up to your sternum. Your diaphragm is basically sitting right underneath there. So that when you guys take a nice deep breath in, that diaphragm contracts or it flexes. Okay, as the diaphragm flexes, it actually pushes down your abdominal cavity. Okay, in order to make room in your chest for the lungs to be able to expand and get that nice big full expansion so that can fill up with lung, increasing the pressure gradients and creating diffusion so that we can get oxygen into our system. Inspiration is known as an active process. I'm going to say that again. Inspiration is known as an active process. It requires energy in order for us to inspire air. Okay? On the opposite end of that, when we exhale, okay, we relax our diaphragm. So our diaphragm actually helps push some of the air out of our body for us, okay, as it relaxes. It closes up the actual space that it just created, and it kind of helps squeeze the lungs a little bit in order to expel the air for us. Exhalation is a passive process, which means it really doesn't require much energy. It still requires energy, but not as much energy as inspiration does. But we call it a passive process, which doesn't really require any energy at all in order for us to breathe appropriately. We do have some muscle groups that help us in the process of breathing. And the main or the primary muscle of breathing is known as the diaphragm. Okay, that is our number one muscle that helps us breathe. The diaphragm is actually controlled by something called the phrenic nerve. Phrenic is spelled P-H-R-E-N-I-C, which branches off of the cervical spine at C3, C4, and C5. So we're going to talk about damage to those spinal nerves when we get into neurology a little bit, specifically when we get into trauma. And if we sever at 3, 4, and 5, more than likely our patient will not be alive. And that's the little kind of remember of that. But the phrenic nerve does branch off 3, 4, and 5, which controls the diaphragm itself. We also have a whole bunch of intercostal muscles. The intercostal muscles are actually in between your ribs. These are the muscles that really help us expand our chest and collapse our chest when we are done with, when we're in the process of exhalation. We could be using our abdominal muscles to help us breathe. We could be using our neck muscles to help us breathe if we are really short of breath. And we can also use our pectoral muscles as well. Respiration is gas exchange. Respiration is gas exchange at the alveoli level, okay? This is where the exchange of oxygen and carbon dioxide intertwine and intermingle and exchange in every single portion of our lung. Again, diffusion, the definition of that is the passive process. Again, passive means it does not require any energy. Is the passive process in which oxygen molecules move from areas of higher concentration to lower concentration, okay? And your brainstem is what controls all of this. Your brainstem controls your rate of breathing, your depth of breathing, and your effort of breathing. We'll talk about that more here in a second. All right, so the brain, the section of the brain that controls our ventilatory cycles is known as the medulla. It is actually stimulated by high carbon dioxide levels. Something that you guys need to understand. Us healthy adults, us healthy people, Okay, we're not smokers, right? We take care of ourselves. We're nice and hydrated, right? We don't breathe to get oxygen. A normal, healthy adult breathes to blow off CO2. I'm going to say that again, okay? All of you healthy guys out there, guys and gals out there, okay? You guys are young, you guys are still healthy, whatnot. Hopefully, you guys aren't smoking. If you are, shame on you. But all you guys that are sitting there, right now, you guys are healthy, okay? You guys are breathing to blow off CO2. It's not to get oxygen. We're going to talk about disease processes, specifically our emphysema patients or our cancer patients or lung cancer patients, or possibly our congestive heart failure patients that breathe in order to get oxygen. It's not necessarily to blow off CO2, but they're breathing to get oxygen. They have completely changed or morphed their physiology of their actual respiratory system due to years of abuse from smoking, or due to secondhand smoke, or due to just being dealt a shitty hand, right? They breathe to get oxygen, not necessarily to blow off CO2. The ponds, it does have two different areas, and we don't really get into the areas, but they're called the dorsal respiratory group and the ventral respiratory group. At least we don't do that in basic land, but it does kind of augment or change our respirations in emotional or physical crises or stress. All right, so we talked about respiration, which is the gas exchange through diffusion and pressure gradients at the alveoli level in our lungs. Moving into ventilation, once again, it's really simple, guys. Ventilation is just the mechanical movement of air in and out of the lungs, period. I breathe in, I breathe out, done. Okay, that is ventilation. Okay, it does require an intact chest wall. Okay, it does require that our intercostals along with our diaphragm work together in order for us to get that full, good chest expansion so that our lungs can inflate fully in order to help us create that pressure gradient in order to help diffuse the oxygen and the CO2 through our lungs. A couple of vocab terms here for you guys. Tidal volume. Tidal volume is the actual amount of air that you guys breathe in and out in a single breath. The average adult male is right around 500 cc's or 500 milliliters, which is about half a liter of air every single time you guys breathe in and out. Residual volume is the actual gas that kind of stents our lungs open, right? There is no way, it is impossible, 100% impossible for you guys to blow out all of the air in your chest cavity, okay? At least consciously, okay? We can have traumatic events where you guys blow both your lungs, and we have significantly decreased the pressure in our chest, and we have to be able to help that out in order to save our patient. We'll talk about that more when we get into trauma. When you talk about the term dead space, it's actually the portion of the respiratory system that is not involved in any gas exchange whatsoever. Dead space is there, and it kind of is associated with residual volume. In a way, when you guys breathe in your 500 cc's, not all 500 cc's is used for gas exchange. Remember, when you guys are breathing in air, your whole body is there to help humidify, moisten, and filter out the air that we breathe. The dead space is there to kind of stent everything open and prepare for the next breath, right? So that dead space is there because it already has oxygen that is, or air that has been humidified, filtered, and moistened, right? Or warmed, I guess I should say, in order for that, when you guys do take that next breath in, we already have some nice clean air instantly going into our lungs in order to help with gas exchange. Okay, when we're talking about what's called minute volume, basically that's your tidal volume times your respiratory rate, right? So if we are Your normal respiratory rate for adults, and again, we're only focusing on adult vital signs in this class. We're going to talk a little bit about pediatric vital signs, but not much. You guys will be held to know all the adult vital signs. And your normal respiratory rate is anywhere between 12 and 20 breaths per minute, right? So basically, if we are breathing, we'll say 12 times a minute, and we multiply that by 500, right? We get, we get 12 times 500. That comes out to 6,000, right? So your minute volume, every minute that you guys breathe, you're breathing in and out about 6 liters, 6,000 cc's or 6,000 mLs. So about 6 liters of air every single minute that you guys are breathing. Okay, so just like the saying goes, right? We're all full of hot air, right? And some people are filled with more hot air than others, but that's what minute volume means. And again, guys, I'm not going to have you do any kind of formulas in this class. This is strictly straight up definitions. Good flashcard time for you guys. Okay. These are going to become a little bit more important to you guys in their understanding when you go to paramedicine, specifically when we start teaching you guys how to do a direct intubation. You guys right now, you guys are working with what's called supraglottic airways, also known as the LMA and the King. You guys can actually go onto the lab shell right now and watch the progressive airway video and your skills videos. And that'll show you kind of the equipment that we're using in order to help somebody breathe. All right, so what is normal breathing? Normal breathing has a normal rate. What's your rate again for adults? Hopefully you all said 12 to 20 breaths per minute. And depth, we want to see that good, adequate chest rise. If we see that good, adequate chest rise, we know for a fact that our patient is getting a good tidal volume. We want it to be regular, okay? We almost kind of want it to be a good, steady tempo, okay? We want to see a good pattern of both inhalation and exhalation. The process of inhalation itself takes about 2 seconds, and exhalation takes about 3 seconds. When you guys look at your skills videos in your lab shell, specifically under the BVM or your bag valve mask, we treat you guys to breathe one breath every 5 to 6 seconds. So it's 1 second in, 5 to 6 seconds out. 1 second in, 5 to 6 seconds out. And that's because we are providing them with breath. It's a little bit more unnatural, and we don't want to overload our patient or possibly hyperinflate the lungs and cause damage to the lung tissue from what we are doing. You guys watching those videos, specifically the progressive airway and the BVM videos, BVM is the most dangerous thing that we do for somebody. Breathing for a patient is the most dangerous thing that we do for our patients. If we do it wrong, or if we do it too fast, too slow, too much air, too little air, we are killing our patient. Okay, we are doing our patient no good whatsoever. If we were doing this all face to face, I would be showing you BVM skills from day one in lab. Okay, so please make sure you guys watch that BVM skills video so that you guys can really kind of get down that timing of 1 second in, one breath every 5 to 6 seconds. Okay, so with the timing, and I'm going to kind of count it out for you guys. All right, here in a sec, let me get my timer up just so you guys can see how this process is actually worked at. Okay, so I have my mask, and I'm holding the mask to the patient's face, and I'm squeezing the bag, right? So this is your tempo, okay? Breathe, 2, 3, 4, 5, 6. Breathe, 2, 3, 4, 5, 6. Breathe, 2, 3, 4, 5, 6. I want you guys to get that tempo down, okay? Because when we're doing the progressive airway, and you guys actually go and pick up all your kits from school in order to do the progressive airway, we will make sure that you guys are bagging your patient appropriately, okay? We are looking for good audible lung sounds. Okay, this is where you guys are going to use your stethoscope and actually start listening to lung sounds, and you guys have a little activity to do in your lab on that as well. And then we want to see very little, but we still want to see some movement of the abdomen. Okay, you guys, we'll talk about people that are actually belly breathers in respiratory emergencies. Usually, when you guys see a heavy abdominal use, the patient's getting tired of breathing. They're running out of energy, okay? And that is a life threat. All right, so we've gone over normal. Let's go over abnormal, okay? Anytime that we see kind of inadequate breathing patterns in our patient, specifically labored breathing, we need to get a decent history of the events that led up to the labored breathing. Okay, did this patient just run 5 miles? Were they doing some kind of physical activity that caused them to have labored breathing, or were they sitting on their couch eating Cheetos and watching The Price is Right, and all of a sudden develop labored breathing? Two completely, totally different situations. Okay, we're going to look at them. We're going to look at how they're breathing. Do we see retractions? Can we see muscle retractions? Can we see them really using their neck muscles? Or can we see them using, can we see their intercostal muscles, the muscles in between the rib cage, kind of being sucked in? Are they really working on breathing? That's something that we want to keep in mind from the instant we actually see our patient. All right. Are they pale? Does the patient look pale? Okay, we're going to talk about the skin here in a little bit. The skin is the largest organ in the body. It is the one organ of the body that we can see. And it's the cover of the book. It makes us want to read it. Okay, if that patient's pale, they might not be getting enough oxygen. Okay, cyanotic, that's kind of like the bluish tinge of the lips. You guys will definitely see in the lips. You guys can see it on the tip of the nose. You guys can see it around the actual eyeballs themselves, the actual like the zygomatic structures. You can actually see cyanosis on some people. You can really see it in some people's hands at times, or even their feet. Are they cool, right? Do they feel cool to the touch? And do they have damp skin? Again, this is all going to go back into the history of your patient. As far as tripod positions, tripod is where you'll see your patient kind of sitting on a chair. They're leaning forward and they're supporting themselves on their knees. Okay, their hands are on their knees and they're kind of supporting themselves up, kind of helping or trying to help, attempting to help with chest expansion. When we talk about tripoding, you guys have all gone for long runs. Maybe you guys played sports in high school or whatever, right? You guys have exercised or something like that. When you guys are short of breath after your run, what do they tell you to do with your arms? Well, they tell you to put your arms on top of your head, right? They don't want you bending at the waist and holding your knees. The body, okay? The body actually feels better when you bend at the waist and kind of hold your knees, but it's a false positive to your brain. Okay, you're actually pushing your abdominal contents up into your diaphragm, making the diaphragm work harder in order to flex and contract. Okay, so we put our hands on top of our head in order to help create that nice, big, full chest expansion. Okay, that's what tripoding is. And then if we talk about agonal gas, we're going to talk about something called guppy breathing in respiratory emergencies, and this is basically like a fish out of water, okay? This is kind of the last sign and symptom before our respiratory system is about to shut down. Okay, guys, moving into our circulatory system, all right? We have all kinds of tubes in our body, ranging all the way from big old plump juicy arteries all the way down to extremely small microscopic capillaries. I read somewhere once, and don't quote me on this, but I remember reading somewhere once, I'm not quite sure where I read it, but apparently if you guys take every artery and vein and capillary in your body, it can like stretch around the world twice or something like that. We are just one big bag of goo, and we have a ton of vasculature throughout our body. We do technically have two different circuits in our body. We have systemic circulation, which provides all of our body with blood, and then we have pulmonary circulation, which is completely different, which is where gas exchange occurs for us, the onloading of oxygen and the offloading of CO2. All right, when we're talking about the heart, okay, the heart is a two-sided pump. One side pumps deoxygenated blood into the lungs, and the other side pumps oxygenated blood to the body. Okay, it is made of very specialized cardiac muscle cells. We've talked about that a little bit. We're going to get more into it specifically when we get into cardiac emergencies, but they are specialized cells, and they're special because they have four properties that other cells don't have, which we'll talk about in the cardiac section, cardiac emergency sections. It's about the size of your fist. It's located on the left side of your chest, and it's divided not only in the right and left heart, but it's also divided from top and bottom, which is atria. The atria are on the top, and the ventricles are on the bottom. Our heart consists of four different chambers. We have our upper chambers, which are the atriums. We have a right and left atrium. Okay, the whole right side of the heart contains nothing but deoxygenated blood. So the right atrium and right ventricle is 100% deoxygenated. Okay, the whole left side of the heart, the left atrium and the left ventricle, is oxygenated blood. Okay. So the right atrium collects deoxygenated blood from the body. It then pushes that deoxygenated blood into the right ventricle, which pumps that deoxygenated blood into the lungs. The gases exchange at the alveoli level in the respiratory system with the blood, and then the blood is dumped into the left atrium, which is now oxygenated, and then into the left ventricle in order to be pushed into the aorta, and the blood is evenly distributed throughout the body as the body needs it. So after the heart pumps blood into the aorta, that is when the heart is actually fed its own blood supply. Okay, there is a branch of the aorta that actually attaches back to the heart. So the heart and the brain are the two organs that get the freshest blood, the freshest oxygenated blood. Okay, so the heart receives its own blood supply from the aorta itself. Okay, the right side of the heart receives deoxygenated blood from the vena cava. You have a superior and an inferior vena cava. The superior, the one on top, superior means top, remember. The superior vena cava drains the blood from the brain back into the right atrium, where the inferior vena cava drains all the blood coming back from all the way down from your big toe and the rest of the body to be drained back into the right atrium as well. Again, that right atrium dumps that blood into the right ventricle, and that right ventricle pumps that blood that's filled with CO2 into the lungs in order to get gas exchange to occur, in order to saturate our blood again and get it fully oxygenated. Okay. Once it's done with that, the blood returns to the left atrium as oxygenated blood, and the left atrium collects that oxygenated blood and then dumps it into the left ventricle, which then pumps out into the aorta. The aorta then feeds the rest of the body. Okay, guys, so this slide's pretty important. This shows you the actual blood flow through the heart. Remember that you guys are looking at that heart as if it is in the patient's body. So your left is the heart's right. Okay, I'm going to repeat that. This is you looking at the heart as if it was sitting in a patient's body. So your left is the right side of the heart. So the blue section on this is the right side of the heart. The whole right side of the heart carries deoxygenated blood. It is rich with CO2. The left side of the heart carries very pure oxygenated blood to the rest of the body. So we're going to go through this because you guys need to know the blood flow through the heart, okay? So you guys can see the inferior and superior vena cava. Both of those dump into the right atrium. From the right atrium, that deoxygenated blood passes through what's called the tricuspid valve, which separates the right atrium from the right ventricle. So the right atrium dumps the blood through the tricuspid valve into the right ventricle. The right ventricle pushes that deoxygenated blood through the pulmonic valve into the pulmonary arteries. Okay? The pulmonary arteries, excuse me, the pulmonary arteries are the only arteries in your body that carry deoxygenated blood. I'm going to repeat that. The pulmonary arteries are the only arteries in your body that carry deoxygenated blood. Okay? From the pulmonary arteries, the blood lands in the lungs, both the right and the left, respectively, where oxygen exchange occurs. Once the blood has been oxygenated, it returns to the left atrium through the pulmonary veins. Okay, you have two sets of pulmonary veins, two on the right, two on the left. All four of those veins are leading to the left atrium. The pulmonary veins are the only veins in the body that carry oxygenated blood. I'll repeat that again. The pulmonary veins are the only veins that carry oxygenated blood in the body. Okay? Those four veins, the right pulmonary veins and the left pulmonary veins, both end up dumping the blood into the left atrium. From the left atrium, it passes through the mitral valve. The mitral valve separates the left atrium from the left ventricle, okay, where it spills that oxygen-rich blood into the left ventricle. The left ventricle squeezes, okay. It goes through the aortic valve into the aorta, and then it's spread throughout the body accordingly, all right. The brain and the heart are the first two organs to get the most oxygen-rich blood in the body, okay. So you guys will have to be able to follow a track of blood through the heart. All right. So I'm going to lay this out again for you guys one more time. And I would definitely write this down, watch this section of the video a couple times, rewind it, whatever you guys want. But I'll make it really easy. Okay. The superior and inferior vena cava. The superior inferior vena cava drains blood from the head. The inferior vena cava drains blood from the body. Okay, all that blood's returning back to the heart. Those both dump into the right atrium. Okay, the heart contracts. The right atrium passes through the blood in the right atrium, which is deoxygenated, goes through the tricuspid valve and lands in the right ventricle. The blood is still deoxygenated. The heart contracts. The right ventricle pushes the blood through the pulmonic valve into the pulmonary artery. The pulmonary artery is the only artery in the body that does not carry oxygenated blood. Okay? The pulmonary artery is the only artery that carries deoxygenated blood in the body. All right? And from the pulmonary artery, it lands in the lungs. Gas exchange occurs. That blood is brought back to the heart through the pulmonary veins. The pulmonary veins are the only veins in the body that carries oxygenated blood. Okay? The four veins, two on the right, two on the left, all end up in the left atrium, where that fresh oxygenated blood is kind of collected. That blood is then pushed through the mitral valve into the left ventricle. The left ventricle contracts, pushes the blood through the aortic valve into the aorta, and the blood is diffused throughout the body, respectively. The normal resting heart rate for adults is anywhere between 60 and 100 beats per minute. Okay, that's normal for us. Anytime it drops below 60, it's a concern. Anytime it gets above 100, it can be a concern as well. when we talk about heart rates, if it drops below 60, we call it bradycardia. Okay, bradycardia is Brady means slow. It's a slow heart rate, and it's usually less than 60 beats per minute. When we talk about a heart rate above 100, it is known as tachycardia, which means that the heart is beating a little faster than we want. Again, when we get into cardiac emergencies, we will have to get a good history of the patient in order to find out why their heart rate is fast or slow. When we talk about stroke volume, again, guys, these are definitions. I'm not going to have you guys do any formulas or anything like that. I just want you guys to know these definitions. When we talk about stroke volume, it's the amount of blood that is moved throughout the body in 1 beat. Okay. When we talk about cardiac output, it's the amount of blood that's moved in about 1 minute throughout the body. Your normal stroke volume for an adult with every beat is about 70 cc's or 70 mLs every beat. Okay. And when we get to about 60 to 70 or 60 to 100 beats per minute, our heart rate, let's say our heart rate's at 70 and our stroke volume's at 70. Our cardiac output is right around 4,900 cc's or right around 5 liters of fluid. The normal average adult carries about 5 to 6 liters of fluid of blood in our body. All right, some vocab here: systemic and pulmonary circulation. Systemic circulation is the movement of blood from the left side of the heart to all the tissues of the body through the aorta, where pulmonary circulation is the movement of blood from the right side of the heart into the lungs to get oxygenated. Okay, make sure you guys understand the difference and know the terms, know the definition of both these terms. I really think once you guys kind of learn the actual blood flow through the heart, this will make a little bit more sense. So make sure you guys know how to track a red blood cell all the way through the heart. Okay, I skipped ahead in the lecture a little bit. You guys can read up on arteries and the branching off of the arteries. Again, this all just for kind of general information. You guys won't necessarily be tested on that stuff. But the difference between systemic capillaries and pulmonary capillaries is pretty much the same thing, kind of, as systemic circulation and pulmonary circulation. When we're talking about systemic capillaries, this allows for distribution of oxygen and other vital nutrients at the cellular level. This is through a process called perfusion. We are now getting into those Fick principles again. We talked about Fick principles 1 and 2 for respiratory. Fick principle 1 was ventilation. Fick principle 2 was respiration. Now we're talking about Fick principle 3 and 4. Fick principle 3 is circulation, so we have to have a good, healthy heart, a pump that can actually circulate the blood. And now we're talking about perfusion. Perfusion is gas exchange at the cellular level. Respiration was gas exchange at the alveoli level in the lungs. Perfusion is now gas exchange at the cellular level throughout the body. And with the systemic capillaries and the pulmonary capillaries, these all work together, but we have to make sure that we have a good pressure in our system in order to get that oxygen molecule to cross over into our systemic capillaries all the way down to our big toe. Okay, so again, systemic capillaries allow for distribution of oxygen and other nutrients at the cellular level, and it also allows to remove the waste, the carbon dioxide and other acids that we find in our body, such as like a lactic acid or stuff like that. Okay. Pulmonary capillaries allow for the delivery of carbon dioxide through the alveolar tissues when exhaled, and it allows for the absorption of oxygen into our body in order to perfuse and provide adequate gas exchange at the cellular level for us. Okay, so Fick principles 3 and 4. Fick principle 3 is circulation. Fick principle 4 is perfusion. Circulation is the movement of blood all around the body. Okay, we need a good, healthy pump, also known as the heart. We need a good, healthy pump in order to get good, adequate circulation. Perfusion is actually the pressure of the blood that's in our system. Okay, it's driven by a force of contractions and size of the blood vessels at any given time, and also depends on the volume of the blood that we actually have in our system. This is going to become a little bit more apparent when we actually start going into trauma. Blood outside of the body is bad. Blood anywhere else but in our veins and arteries and capillaries is bad for us. We want to try to keep everything into the system, okay? And we need an adequate pressure. Again, it's just like that pressure gradient when we're talking about respiratory, right? We have to have a good pressure in our system in order to make gas exchange occur all the way down to the cells in my big toe. When we're talking about pressure, we're obviously talking about our blood pressure, okay? Our blood pressure is the pressure that the blood exerts against the walls of the arteries. Okay? How much force is that blood being pumped out of our heart into our arteries? Okay? When we're talking about our systole or systolic blood pressure, you guys know normal blood pressures as 120 over 80, right? You guys have heard that your whole lives probably, that a blood pressure right around 120 over 80 is perfect. Well, the systole is the 120 part. That's the top number, okay? The top number is when the left ventricle of the heart contracts and it pumps the blood from the ventricle into the aorta, okay? So your systole is how much pressure is that blood being forcefully pumped out of the left ventricle and enter into the systemic circulation to go throughout the body. Diastole, or the diastolic blood pressure, on the other hand, is the bottom number. Okay, diastole is when the muscle of the ventricle actually relaxes and the ventricle actually fills up with blood. Okay, so it's actually showing us the actual squeeze of the pump or the actual heart itself. How much squeeze is the heart actually doing for systole in order to eject all the blood out of the left ventricle, and how much relaxation does the heart actually occur before the next squeeze is your diastolic blood pressure. Okay, obviously we want our diastolic blood pressure to be as low as possible. Okay, we don't want it too low. All right, too low of a diastolic blood pressure is not good. So here are your normal, quote unquote, normal blood pressures that we want for you guys. A normal systolic is anywhere between 90 and 140 millimeters of mercury. Okay, millimeters of mercury is put as lowercase m, capital H, lowercase g. Okay, millimeters of mercury. Okay, anywhere between 90 and 140. Once we get above 140, we're considered to have high blood pressure in our systolic. Once we get below 90, we are considered to have low blood pressure in our systolic. As far as diastole, okay, we want our diastolic to be anywhere between 60 and 90 millimeters of mercury. Okay, so on the low range, we're below 60 millimeters of mercury for our diastolic, and for our high range, we are above 90 millimeters of mercury for our diastolic. Okay. So you cut those kind of numbers in half, and that's where you get your normal blood pressure of 120 over 80. All right. Guys, you guys are going to see outrageous blood pressures. Some of you guys might even have high blood pressure. Some of you guys might even have high blood pressure and not even know it. That's why it's called the silent killer. We're going to talk about that when we get into cardiac emergencies. Okay, guys, again, you guys are going to see that I did jump ahead. You guys can read over the actual normal circulation and inadequate circulation in adults on your own. Okay, I will definitely cover that more when we get into cardiac emergencies. So, what is the function of our blood? What does our blood do for us? The big thing that the blood does is it transports oxygen. Your red blood cells have a protein structure on it called hemoglobin. The hemoglobin is where the oxygen molecule actually attaches and is carried throughout your body in order for gas exchange to occur all the way down to your big toe. Once that oxygen molecule is released from your red blood cell, it attaches the CO2 onto it. That CO2 is then taken back up towards the heart through the inferior vena cava, where it drops into the right atrium, and the process starts over and over and over and over again. Okay, so the big thing is transportation of oxygen, the transportation of carbon dioxide. It's also there to help fight infections. Okay, your blood, the composition of your blood. You guys have red blood cells. You have white blood cells, which helps in fight infections. You guys also have platelets, which help with clotting factors. Right? You guys cut yourself. You guys develop that scab. That's really like millions of platelets just kind of coming together to stop the bleeding for you. It helps transport waste and nutrients throughout our body. It helps control our pH. We're going to talk about pH towards the end of this lecture. pH is also known as your acid-base balance, okay, or how you guys maintain your homeostasis. You guys might have heard that word before. And like I said, the clotting factors with your platelets as well. Okay, now starting the nervous system, also part of the big three: respiratory, cardiac, and neuro. The nervous system is extremely complex. I'm going to try to explain this as best as possible to you guys. Again, I'm going to try to keep this as basic as possible for you guys so that you guys can get an understanding of this. You guys will get a metric poop ton of this when you guys get into paramedic, if you guys are going that route. But for now, let's keep it as basic as possible, okay? So your nervous system is divided into two main portions. We have the central nervous system, which basically contains the brain and the spinal cord. And the peripheral nervous system is all the nerves that are coming off the spinal cord throughout your body, touching pretty much every single organ and every single tissue in your body as well. Okay, so your sympathetic nervous system is also known as your fight or flight. You guys had the pharmacology lecture with me. You guys know that some of your drugs are known as sympathomimetics, which means they mimic the sympathetic nervous system. This is what this does, okay? The sympathetic nervous system sends commands to your adrenal glands. Your adrenal glands will release adrenaline to help you get out of a situation, okay? It's your body's natural defense in order to stay alive. So again, the example that I gave you guys during our pharmacology lecture is I get you guys butt naked, right? I throw a whole bunch of bloody steaks on you, and I throw you into a 6x6 room with a Bengal tiger who hasn't eaten in 2 weeks. Okay? I am going to stimulate your sympathetic nervous system pretty damn quick. Okay? It releases epinephrine. It's also known as adrenaline. And then it also has norepinephrine, which is actually a little stronger kick, if you will, than the actual epinephrine itself. And it's the adrenal glands will secrete that into the blood, so that when that blood returns to the heart, and it happens pretty quick, guys, when that blood returns to the heart realizes, oh my God, for whatever reason, I'm getting this signal from the adrenal glands. I'm getting drunk off of all this epinephrine. I got to do something, and usually that stimulates the heart to start to pump faster. Okay, so when we're talking about the actual nervous system and the control of the cardiovascular system, your blood vessels have something that's called alpha adrenergic receptors. Alpha receptors are, anytime you see alpha adrenergic or the word adrenergic, it's talking about adrenaline. It's talking about the sympathetic nervous system, okay? Alpha adrenergic receptors are all over our body, okay? They will take in signals specifically from our nervous system in order to stimulate something, okay? So when you stimulate your sympathetic nervous system, put yourself back in the situation where I throw you guys in the room with a Bengal tiger. What's going to happen with your body, okay? You're going to get scared, okay? Your body is going to release that adrenaline. You're going to feel that rush. Your heart rate's going to go up. Your ventilatory rate's going to go up. You're going to start taking nice, big, deeper breaths, okay? Your pupils are actually going to dilate, okay? Your pupils are going to dilate because you're going to try to soak in as much light as you can in order to help you find the exit, okay? It stimulates our sweat receptors because our heart's pumping faster, because we're breathing faster, we're creating more heat in our body. So naturally, our body's going to start to sweat in order to kind of keep us cool. Okay? Your heart and lungs have what's called beta adrenergic receptors. There's beta 1 receptors and beta 2 receptors. I'll make this very easy for you guys. You have 2 lungs, so your beta 2 receptors are found in your lungs. And you have 1 heart, so your beta 1 receptors are found in your heart. Okay? And then we have something called the parasympathetic nervous system. This also has some kind of effect on the cardiovascular system, and it really addresses actions that do not need or require immediate attention. So we're going to talk about the parasympathetic nervous system, I believe, coming up here. But basically, your parasympathetic nervous system is your rest and digest system. It's when you guys go to grandma's house and it's Thanksgiving and your grandma thinks you look a little too skinny or a little too pale, and she starts shoving all that stuffing and scalloped potatoes and turkey and whatever the hell else you guys eat at Thanksgiving down your throat, right? And then you guys all of a sudden start to get tired, okay? Because you have basically kind of stopped stimulating your sympathetic nervous system because you got all this food in your belly and it's hard to breathe and you got to undo your belt buckle. You know how it is. And all that blood is kind of moving down into your belly in order to start digesting all that yummy food that you just ate, right? So naturally, with the parasympathetic nervous system, your heart rate's going to go down, your ventilatory rate's going to go down, your eyes are actually going to constrict, your pupils will actually constrict because you don't need to take in that light because there is no threat to you. You're sitting there chilling, about to go into your food coma. Okay, so this is a good graphic for you guys to kind of try to help to put all this together. Your central nervous system, the only 2 things in your central nervous system is your brain and your spinal cord. That's it. Okay. It receives information from the rest of the body in order to function. Okay. From the central nervous system, we go into the peripheral nervous system, and those are the nerves that collect all the parts of the body to your brain. Basically, the peripheral nervous system is all the nerves that are branching out of your spinal cord or your spinal column, all the way to your fingertips and your big toes. Okay. The peripheral nervous system is actually broken down into 2 separate divisions. We have a sensory division and a motor division. Okay, I'm going to spend a little time on this. I want you guys to pay attention to this. Sensory and motor. You guys sense something and it causes a motor response, and it's pretty quick. Okay, in your normal average adult, this is within like milliseconds. Okay, so I'll give you an example. All right, the sensory nervous system, it actually conducts information from your organs or internal organs back to your central nervous system. So let's say the nerves in my hand, okay, the nerves in my fingertips. I put my hand on a hot stove, okay. I set my hand on a hot stove. That signal instantly goes from my sensory nervous system all the way back to my spinal cord. The brain realizes, hey, I don't like this, okay. This is a little too hot for me, and it instantly sends a signal through the motor division, all right, to move my hand. So sensory comes from outside in, motor comes from inside out, okay, and it's split second. Boom. In a healthy adult, it is pretty quick. You touch that stove, it's hot, you pull your hand off. That's sensory and motor, okay. Your motor system is broken down into 2 other parts: the autonomic nervous system and the somatic nervous system, okay. Your somatic nervous system controls all of your voluntary muscles, period. That's all it does, okay. However, your autonomic nervous system is impulses from the CNS to all your organs and glands, and this the autonomic nervous system is now broken down into the sympathetic, which is your fight or flight, and your parasympathetic, which is your rest and digest. Okay, guys, I kind of flew through the nervous system for you guys. I did skip over some of the PowerPoints. You guys can go back and read over those for a little bit better explanation. Again, I will cover the nervous system one more time when we get into neurological emergencies. We're going to move into the skin now, the integumentary system. which is your skin. It is the largest single organ in your body, and it has three functions. It protects our body from environment. It helps regulate our body temperature, and it helps actually protect us from becoming dehydrated or losing fluids. And it really transmits information from our outside environment all the way into our brain to sense if we are in danger or we need to up and leave, or if everything is cool, calm, and collected. Okay. Again, this is the only organ system that we see. Okay. The skin can tell us a lot about our patient. If they're pale or cyanotic, or if they have a rash, or if they have urticaria, which you might see in an allergic reaction. And we'll definitely be talking about the skin a lot. Remember, your skin is a vital sign. The skin that we want to see is nice and pink, nice and warm, and nice and dry. That's what we're looking for when we're talking about vital signs as far as skin color. Okay, so your skin is broken down into three separate layers. Your epidermis is the top layer. Epi in Latin means above. So this is actually above your dermis. So this is the top layer. Your epidermis is basically a whole bunch of dead skin cells that kind of create this protective barrier over the rest of our body. The dermis, okay, the dermis of the skin, the dermis layer of the skin is where all your blood vessels are located, okay, as far as some capillaries and veins and whatnot. Your hair follicles are all there, along with your sweat glands and oil glands. And this is the layer that actually contains all your nerve endings as well throughout your skin. We're going to really get into skin, and this specifically, the layers of the skin, when we talk about burns and trauma. Your subcutaneous tissue is basically your fat, the fat that's on your body. It helps to insulate, it cushions us, and it holds on to water for us and other nutrients, and we burn it when we need to. Okay, moving into the digestive system. The digestive system is well, it's kind of boring, right? It's there to soak up water. It's there to process nutrients after we feed it, and it's there to expel everything that we don't need as far as creating poop for us. Okay. So it's definitely the process of digestion is known as the process of food that nourishes our cells. Your abdomen, almost 90% of your digestive system is contained in your abdomen. Remember, we do have the extension of the esophagus, and your mouth is technically part of your digestive system as well. So your abdomen is your second major body cavity. Remember, it is right below the thorax, which is separated by the thorax, and the abdominal cavity is separated by the diaphragm. It's organized into four different quadrants: the right and left upper quadrant and the right and left lower quadrant. We do that. We separate into the four quadrants at the basic level so that you guys can kind of figure out if we do have an injury to the abdomen. We can kind of figure out what might be what organs might be lying underneath that injury based on these four quadrants. When you guys move up in level of licensure, specifically when you get to paramedic, we will turn these four quadrants into 9 separate quadrants. When we're talking about the right and left upper and lower quadrant, it's basically as if you guys put a bullseye on your belly button and you divide it into the four quadrants that way. Okay, so this is a picture of the abdomen divided into the 4 quadrants, so you can kind of get a glimpse of what is in each quadrant. As of now, you guys do not need to know the vessels or the organs that are lying within each quadrant. However, you guys will need to know as we are moving on in the semester, specifically when we get to our trauma, on what vessels lie in each quadrant. And remember, when you guys are looking at this, the picture there, your left is their right, okay? So don't let that get you confused. It happens every semester. Make sure that you are looking at it from the patient's point of view, not your own point of view. Okay, so you guys are eating your Wendy's fries that you're dipping in your chocolate frosty, right? And while you're doing that, your mouth starts to produce saliva. You guys start salivating because maybe you're not able to eat it and you're watching somebody else eat it. But either way, you guys are actually adding enzymes to your food, and it all starts with your saliva. In your saliva, you have an enzyme called amylase. It's AMYLASE, I believe. It could be CE, but I think it's SE. And it's actually an enzyme that actually starts breaking down the food for us. And remember, when you guys are chewing, you guys are creating that little ball of food, that little ball of goo known as the bolus, in order to help you swallow that food for you. Okay. So the enzymes, once you guys kind of start to swallow it, your stomach plays a huge role, right, in breaking down the fluid. Your liver plays a little bit. Your pancreas produces insulin in order to get the sugar into our cells for us. We'll talk about that more in the endocrine system. And then your small intestine is there to actually soak up all the nutrients and kind of spread it throughout the body. All your food is converted into a couple different things. It converts into basic sugars. It converts into fatty acids and amino acids. Okay, that's all the body cares about. All right. This is further processed by the liver, and it's circulated throughout your blood. After that, your food, once it gets through the small intestine, it then goes into the large intestine. And your large intestine is actually broke down into 3 different areas, and we're not going to talk about that until we get into abdominal emergencies. But the goal of your large intestine is basically to suck up water. Okay, it's to take all that stuff that the body didn't need through the small intestine. All the body wants is basic sugars, fatty acids, and amino acids. Everything else is then processed into the large intestine, where that large intestine, excuse me, really acts as a sponge, right? And it soaks up all that water, and it creates poop. It makes all that nasty food that your body doesn't want, or all those nasty preservatives or whatever else you guys are eating, and it creates it into a hard substance, and then you guys poop it out. Now, let's talk about pooping. A normal poop, okay? Like, let's have a serious conversation here. You guys should not be going to the toilet and respackling the toilet with diarrhea every single time that you guys go to the bathroom. Okay? There's a big movement on gut health right now in our country. And they're really finding out that this is very, very important to us. So we don't want to have diarrhea all the time. We also don't want to be constipated all the time. Okay, when you guys are constipated, you guys are technically not getting all the poop out of your system, and constipation technically leads to diarrhea. In order for your body to try to expel all the food that you guys are not eating. So that's why we want to make sure that we're drinking plenty of water, throughout the day. That's why they're telling you guys that you guys should just eat and eat and eat and eat. And then once you guys are done eating, that's when you guys should start drinking water. You guys shouldn't be drinking while you're eating. I'm guilty of that. I can't do that. I can't not wash my food down. But again, you should have a nice brown piece of stool with a beautiful J curve in it. That's what a normal healthy poop is. Again, if you guys are respackling the toilet every single time that you go there because you guys are just flinging diarrhea out of your rectum, you guys probably should either change your diet or probably go see a doctor. There could be something considerably wrong with you. Okay, moving into the lymphatic system. We don't really play too much with this in EMS. I just kind of want you guys to know that it's there. I did skip ahead a little bit in the slides, but there are certain elements of the lymphatic system, such as your lymph nodes, your lymph vessels, the lymph itself, your spleen, okay, which is probably the biggest organ that we deal with in the lymphatic system. Your spleen is actually a reservoir for blood. It holds about 500 cc's of blood. at all times of kind of like packed red blood cells, I guess is the best way to put it, to be used by the body in case of an emergency. And it's also there to help us produce antibodies to help fight infections as well. And then we also have the thymus gland. Really, what the lymphatic system does is it supports the circulatory system and the immune system. It's a straw-colored fluid that carries oxygen and nutrients to cells and waste products away, and it really helps to rid your body of toxins or other other harmful materials. Think of this as like the cleansing system of the body. It can give us some problems, specifically if we develop a cancer in the lymph, because it does spread through the body very quickly. But we really don't work with the lymph too much as far as emergency medicine. Okay, the endocrine system also I'm not going to spend too much time on right now. I will definitely get more into the endocrine system when we get into our like diabetic emergencies and stuff like that. Our endocrine system produces hormones. That's really all it does for us. And hormones are very important to us because it does help us with the actual functions of the body. We have many glands as part as the endocrine system. We have the pituitary gland, which is found in our brain. It's very small. It's known as the master gland. It kind of has rank over all the other glands that are listed on this slide. The thyroid gland we'll talk about more when we get into endocrine, along with the parathyroid and the adrenal glands we've already talked about a little bit as far as producing adrenaline with us. However, the endocrine system also has a little bit to do with our reproductive system, specifically our ovaries in our females and our testicles in our males. Those are technically part of the endocrine system. And then our pancreas, which is kind of the regulator of our endocrine system, it helps us, it produces insulin for our body in order to get glucose into our cells to help our cells produce energy. And like I said, we'll talk about that more when we get into diabetic emergencies. Okay, our urinary system contains our kidneys, our ureter, which is the actual tubing that leads to our kidneys to our bladder. It contains our bladder, and then from our bladder, it goes through our urethra in order to be urinated out. And really, all the urinary system does is it controls our fluid balances in our body, specifically our kidneys. It helps control our salt and potassiums. It filters and eliminates waste, specifically that waste being lactic acid, not necessarily carbon dioxide, but now we're talking about lactic acid. And then it helps control our homeostasis or our acid-base balance. Okay, genital system for our males. Your males, your genital system is 70% outside of our body. And we do this because we need to keep things cool. We don't want certain areas to get too hot for us. We want to try to keep things cool, specifically our testicles, okay? And again, remember that the testicles are also involved in the endocrine system. But you can kind of see how this is all kind of, intertwined in our body. Guys, I don't think I have to share this with you, but ladies, there is a lot of nerve endings down here, and we can get some pretty serious problems when it comes down to this area. The slightest trauma can be very debilitating for our males. This is an area that we protect with our life. Right? This is an area that we do not want injured in any way, shape, or form. This is an area that is very important to us as males, as far as making sure that it is functioning appropriately and that we are not experiencing any trauma to this area. So again, we have our ureters, which are, you can see in the front view there. Sorry, in the front view, you can see our ureters. Those are coming from our kidneys. That goes into our bladder. And it fills up our bladder. From the actual bladder, it goes through the prostate gland, which can give us some problems in middle-aged and late-aged for us, we can have what's called benign prostate hypertrophy, which means our prostate is actually enlarged. And as that swells up, it can actually cut off our flow of our urinary tract, which makes it hard for us to actually evacuate all of our urine at one time. And then we have our penis, which is our external genitalia, right? It is basically a muscle, and it swells with blood. And yes, guys, you can fracture your penis. It's usually due to intense sexual intercourse. And from my understanding, I've never experienced it, but it is extremely painful. And you guys can see on that front view there the actual musculature of the penis itself, where the urethra kind of runs through the middle there. We're going to talk about injuries to the penis later on this semester, and how debilitating it can be for our males. Okay, ladies, moving on to your genitalia. Guys, pay attention. This is probably one of the most complex area in medicine that you will ever deal with. Ladies, I have much respect for all of you. You guys are amazing organisms. This whole system is designed for the miracle of life, okay? This whole system is designed for you guys to give birth to babies, okay? And we can have serious complications, specifically with female genitalia, okay? A ton of stuff can go wrong real quick. Guys, we're easy, okay? We just want to make sure that we don't lose our penis, right? That's really all we care about, okay? Ladies, you can have all kinds of stuff go wrong with this, and it can happen real quick. So, a ton of nerve endings, a ton of hormone production, a ton of vasculature is all in the female genitalia. It is technically more susceptible to damage than the males. However, the female anatomy can handle damage better than the male anatomy can. Okay, so there's your front view. All right, and we're going to start with the ovaries. Ladies, your ovaries and guys, ovaries are basically the testicles of the female. Okay, they happen to be internal though. Okay, we want those ovaries to stay nice and warm. We want those ovaries to stay nice and moist, and we want them to live in a very dark place in order for them to maintain happiness. Okay, the ovaries release an ovum, which is known as the egg. The ovaries are technically not connected to the fallopian tubes. Guys, the fallopian tubes are the things next to the ovaries there. Kind of look like those little hair-like structures there. This is all 100% based on hormone release, okay? So the ovary releases an egg. Ladies, you guys stimulate a hormone called follicle-stimulating hormone, which actually gets that cilia, or those hair-like structures at the end of the fallopian tubes, and they start to kind of brush inward, right? Kind of making that ovum or the egg go into the fallopian tube, okay? From there, and we'll talk about this more when we get into our GIGU chapters on emergencies. We're hoping that egg meets sperm, right? If that egg meets sperm, hopefully it's met in the fallopian tube itself, where the egg is fertilized, and then the egg continues to go down into the uterus. The uterus is a huge, monstrous, muscular structure. Okay, it is ginormous. It is strong. It can contract like nothing else in the body. All right, lots of vasculature, lots of blood going to this area, lots of nerve endings going to this area. Okay, if the egg is fertilized, hopefully it implants in the uterus, and we'll talk about pregnancy later on this semester. The uterus then goes into the cervix, and then the opening is known as the vagina. Okay, and we will talk more about female anatomy later on this semester. Homeostasis. The body's everyday 24/7, 365 battle to maintain homeostasis. Okay? I want you guys to understand something right now. The human body does not obtain complete 100% homeostasis until we are dead. Okay? We are constantly going back and forth between an acidic and an alkalotic, or an acidic and basic state, 24/7, 365, all the time, while we're sleeping, while we're eating, while we're studying, while we're listening to these lectures, while we're out playing with our friends, while we're out having a good time. Always. The only time we reach complete homeostasis is when we have died. Okay? We are going to be treating people that have problems maintaining their homeostasis. Okay? They cannot adapt to changes or events happening inside or outside of their bodies. All right? So this is something that we're going to spend a little bit of time on. I'm not going to spend too much time, but I do think that this is important enough to, specifically for you guys going to intermediate or paramedic, this is something that you really got to get a grasp on. Okay, so cells need oxygen to produce energy and to help convert nutrients into chemical energy through metabolism. Our cells, if we are in an aerobic metabolism, which means that we are getting plenty of oxygen to our cells, or the adequate amount of oxygen to our cells, produces something called ATP, also known as adenosine triphosphate. Okay? Adenosine triphosphate is the energy that our body needs in order to survive. Okay? And the only way that we can achieve good homeostasis is if we have a good respiratory, circulatory, neurologic, endocrine, all of our body systems has to be working with each other in order to maintain homeostasis. So aerobic metabolism, when I'm talking about aerobic metabolism, it means that I am getting enough oxygen to my cells. Okay? When cells switch to an anaerobic metabolism, that means that oxygen is limited or not getting oxygen at all. We start producing lactic acid. When we start producing lactic acid, that lactic acid spews into our system. That lactic acid comes into contact with all of our cells. That lactic acid will start damaging the protein structure of our cellular walls, and it'll start spilling all the nasty contents from our cells, specifically potassium, into our system, which can cause all kinds of problems, specifically with our heart rhythm. Okay? So lactic acid is just like CO2. It is bad. We do not want lactic acid in our system. You guys have all experienced lactic acid at some point. Okay? Maybe you guys were out running and you developed a cramp. Okay? That is a localized lactic acid buildup. Okay? You guys aren't getting enough water, you didn't properly stretch, or you guys aren't breathing or have been trained to breathe appropriately in order to get the oxygen to those cells. Whenever you guys develop that little muscle cramp, right, that is a buildup of lactic acid. Little buildups of lactic acid like that are not bad. When it's localized, it's not bad. But when it turns into systemic, we can have major health problems, and our patients can die. Okay, so aerobic metabolism uses oxygen. Anaerobic metabolism uses no oxygen at all, or oxygen is very limited. Either way, the goal is to try to produce adenosine triphosphate. When we are in an aerobic metabolism, and again, this is just for knowledge, you guys don't need to know this for your test, but when we are in an aerobic metabolism, our cells can produce up to 36 units of ATP. Each cell in our body can produce up to 36 units of ATP, which gives us enough energy to get through our day. If we reach an anaerobic metabolism, that drops to 2 to 4 ATP per cell in the body. Okay, so big difference between aerobic and anaerobic. All I need you guys to know is that anaerobic is without oxygen, aerobic is with oxygen. Okay, so I skipped ahead again, specifically with oxygen demand, because you guys just need to know that aerobic metabolism is good, anaerobic metabolism is bad. Okay, and the body always needs oxygen. Every single cell needs oxygen. And brain death can occur within 4 minutes of not having oxygen. That's going to become a little bit more apparent when we talk about respiratory and cardiac emergencies. When we're talking about nutrients, specifically glucose, which is sugar in our body, it's used in all cells. Okay, the brain uses glucose directly for energy as for its cells. Guys, the brain loves sugar. Okay, I always tell it as the brain is a sugar prostitute, right? It wants its sugar. Okay, it loves its sugar. It wants it all the time. Okay, the brain is the only organ in the body that does not need insulin to process sugar. It is the first to get sugar before all the other cells in the body. Okay, so your next vital sign is your BGL, or your blood glucose level, and you guys can see how to check a blood glucose level in your skills lab. We have two different actual BGL readings. In the state of New Mexico, we're reading anywhere between 60 milligrams per deciliter, which is borderline low, and then all the way up to 120 milligrams per deciliter. Okay, the 80 to 120 milligrams per deciliter is the national scope. In New Mexico, we use 60. We lower down that low end because we do have a very big population of diabetics, actually one of the highest concentrations of diabetics in the country. And we use anywhere between 60 to 120 milligrams of deciliters, and we'll talk about more of that in endocrine. Okay, talking waste removal, remember that CO2 is the byproduct of aerobic metabolism, right? If we have enough oxygen in our system, that oxygen should be exchanging with CO2 due to diffusion and pressure gradients. So CO2 is the byproduct of aerobic metabolism. Your CO2 is monitored 24/7, 365 by the cerebral spinal fluid found in your skull that surrounds your brain. Your cerebral spinal fluid is there to kind of provide nutrients for the brain, but it's also a chemoreceptor. It monitors all your chemical levels at all times in your brain. The brain, if it notices high elevations of CO2, okay, if the brain notices high elevations of CO2, it is going to increase your respiratory rate. CO2 and respiratory rate always follow each other. I'm going to repeat that. CO2 and respiratory rates always go in the same direction. Okay? So if your CO2 is going up in your body, as soon as your brain realizes that your CO2 is going up, it's going to elevate your respiratory rate in order for you guys to blow off that CO2. Once it blows off that CO2 to a normal level, okay, the respiratory rate will start coming down as well. All right? If the body has too low of CO2, okay, if the body has low CO2 levels, it's going to drop your respiratory rate. All right? So if your CO2 gets too low, your body's actually going to slow down your respiratory rate to stop you from breathing too fast. Okay? So that you guys can retain the CO2. Going into your acid-base balance of the actual body itself, this is both aerobic and anaerobic metabolism and how this affects the actual pH of the body. Okay? So pH is basically a scale from 1 to 14. Okay? The lower the number, the more acidic your patient is. The higher the number, the more basic your patient is. So let's talk about this for a second. When we're talking about a scale from 1 to 14, a pH of 1 is like battery acid. Battery acid is the most corrosive stuff on the face of the planet, okay? And when we're talking about 14, the most basic thing on the planet is bleach. That's why we use it to clean, because it kills everything, the good and the bad, right? We, as normal adults, sit anywhere between 7.35 and 7.45. Guys, that's a very, very small scale. And we're living in this very small scale all the time. Okay, so I want you to look at this slide. Okay, according to this slide, can we live in an acidotic state longer or an alkalotic state longer? Hopefully you guys chose acidic. we can live in an acidic state much longer than we can live in an alkalotic state. Okay, and we don't get too much into acid-base balance in basic land a lot, and really we talk about it quite a bit in paramedic school. But for those of you guys that are looking to become like flight medics or nurses or critical care nurses or doctors, this is something that you'll definitely want to read up in your book, because I want to keep it pretty simple for you guys. Okay. So again, we live right in between 7.35 and 7.45. A perfect pH for adults is 7.4, which is right dead square in the middle of 7.35 and 7.45. Okay. So the normal acidity or the normal pH of our blood, if we do a blood test, is anywhere between 7.35 and 7.45. And we are constantly adjusting this 24/7, 365. Okay. If we become too alkalotic, we can't get too much alkalotic, right? Only 0.4 more before we actually really start thinking about this patient's going to start circling the toilet and possibly die, right? Where that acidic, we have a little bit more play, right? Once we get down to about 6.8, we start killing off our cells. And if we start dropping any more than that, then more than likely we are going to lose our patient, okay? So that's really all I want to get into with the acid-base component of this lecture, all right? I think we are going to stop there for acid-base balance. Okay, guys, I did skip ahead quite a bit. I skipped over some pathology stuff, some pathophysiology stuff. Make sure that you guys go back through and read that stuff. I'm going to go, like I said, throughout this whole, throughout all these lectures, I will go back over that stuff when we get into the actual disease processes. But make sure that you guys look over that stuff before you guys move on to your respiratory and cardiac and neurologic emergencies. Shock. Shock is one of our enemies in EMS. We have two main enemies in EMS. Shock is one of them. The other one is intracranial pressure. Shock we can do a lot with as long as we are able to recognize the signs and symptoms of shock. As far as intracranial pressure, we'll talk about that more when we get into neurologic just a little bit, and specifically when we get into trauma. We can't do anything about intracranial pressure. That patient needs to go to the hospital real quick, and hopefully they end up on the surgical table real fast, okay? Intracranial pressure is basically the brain is swelling inside the skull, okay? So the definition of shock, I'm going to make this really easy for you, okay? 3 words: inadequate tissue perfusion. We are not getting gas exchange, period. Okay, you're going to see all kinds of definitions out there for shock. Okay, some of them are extremely extensive. 3 words: inadequate tissue perfusion. That's all it is. For whatever reason, I am not able to get oxygen to my cells. I'm not able to convert oxygen into energy. I'm not able to process glucose. And this is now going into a systemic problem in our body in which the patient goes into shock. Okay. However, there are different types of shock that we will go over. The effects of shock on the body can be deadly. The level of oxygen supplies to the tissue falls. Cells start going into a anaerobic metabolism. We have a severe acidosis that is developing metabolically, which means it's basically going from head to toe. We start releasing a bunch of epinephrine and norepinephrine because our body doesn't realize what is going on. For whatever reason, we have this huge kind of like histamine release because our cells are dying and the brain doesn't know what's going on. The brain stimulates the epinephrine and norepinephrine to be released because it automatically goes into a sympathetic drive because the body realizes that something's wrong and the brain's trying to catch up. Your heart rate increases, and it will continue to increase until you are dead. And again, when our heart starts pumping fast, it is burning up a lot of energy, and we might not necessarily be able to keep up with that energy demand, right? If our heart starts beating faster, our respiratory rate's going to start beating fast or start breathing faster, and we can just go into a spiral effect of just losing our patient. Okay, and we're going to talk about shock more in the upcoming lectures, but this is just to kind of give you guys a little bit of a taste of it. Okay, you guys can technically think of shock as an imbalance in our pH. We are either too acidic or we're too alkalotic. Okay, and we are causing major damage to our system, and most of the time it's because we are not getting oxygen to our cells appropriately for whatever reason. All right, and like I said, we'll talk about shock later on in the course. However, basically shock, once again, that inadequate tissue perfusion, this results in the ability to properly use oxygen and glucose at the cellular level for whatever reason. Okay, and there's numerous reasons why shock can occur, and we'll talk about those later. Cells create energy. The cells start to create energy through an anaerobic metabolism, which is bad, so we're not creating all the energy that we should be as if we were in an aerobic metabolism. Remember, we're trying to produce ATP, or that adenosine triphosphate. When we're in an aerobic metabolism, we're producing anywhere between 32 to 36 units of ATP per cell. When we drop into an anaerobic, we're anywhere between 2 and 4 ATP per cell. Okay, brain cells cannot use alternate fuels. It needs oxygen, it needs sugar, period. Okay? The brain doesn't get that. The brain starts getting pissed off. The brain starts getting pissed off. It's going to start shutting down body systems that it does not need. And it usually starts with the kidneys. Okay? It starts to shut down the kidneys. If we have a patient shutting down their kidneys, okay, we are producing massive amounts of lactic acid that we cannot expel, because the only way this body expels lactic acid is by peeing it out. And the kidneys are there to actually filter all that nasty lactic acid for us and expel it through our urine. Here's a fun fact for you guys. When we're doing CPR, okay, the number one goal for CPR, okay, and I know this sounds bad, right? But the number one goal for CPR is technically to perfuse the brain, right? We are trying to perfuse the brain. We are acting as the pump. We are trying to keep the circulation of the blood going in order to deliver the oxygen to our patient, in order to deliver the oxygen that we're giving our patient to the brain. Okay. However, the real reason why we're doing CPR is to keep the kidneys functioning. The kidneys are the first thing to be shut down by the brain when the brain gets into trouble. If we can keep the kidneys functioning, if we could do such good CPR, right, that not only are we perfusing the brain, but we're actually starting to perfuse the kidneys as well, our patient has a chance of walking out of that hospital. Okay? If we are doing CPR and we are doing so poor CPR, or we're not changing compressors every 5 cycles or 2 minutes, right? And we start getting sloppy on our CPR, we are not going to perfuse our kidneys, and more than likely, we are not going to get our patient back. We're going to talk about that more in cardiac. So how do we become acidotic? How do we develop acidosis in our body? Acidosis means that we have too much acid in our body, okay? One way that we can do that is if our patient is hypoventilating. They are breathing too slow, okay? If they are breathing too slow, they are not blowing off the CO2 that they should be, so the CO2, the acid, is building up in our body, so we are becoming more acidic, okay? Our patient might have tried to commit suicide and taken an actual acid. They have ingested an acid, and the big one is aspirin, right? Aspirin is extremely acidic to us. And if we ingest too much aspirin, obviously we will begin to become acidotic. The other way that we can become acidic is if we are suffering from diarrhea. And I'm not talking like a couple bouts here and there. I'm talking when this is like days. When we get that call for the person that is complaining of diarrhea, they are becoming more acidic, okay? Diarrhea, when your stool is a base, okay? It's alkalotic, All right. So when we lose too much base out of our rectum or base out the butt with diarrhea, if we are losing base, we are obviously becoming more acidic. In contrast to the acidosis, how do we become alkalotic? Right? We don't have enough acid, or we have too much base. Okay. We can develop this if we are hyperventilating, if somebody is having a panic attack or a nervous breakdown, however you want to put it, anxiety attack, okay? And they're hyperventilating. We are blowing off too much CO2. We are not retaining that CO2 in our body for a good, healthy level. We're blowing it off too much, and we are becoming more basic or alkalotic in our body, okay? Antacids, okay? People try to overdose themselves on Malox. You guys will run overdoses on people that drink bleach. And I'll tell you something, people that drink bleach, they're usually pretty successful at committing suicide. Okay? That is the most basic stuff on the face of the planet. And as soon as that bleach comes in contact with the tissues of the body, specifically our internal tissues or our esophagus, it can actually necrotize or melt your tissues away and just spilling massive amounts of nasty stuff into our system. But Malox, people will try to commit suicide with Malox, or they accidentally double or triple up throughout the day or whatnot. Whatever the story is, okay. If you're doing an antacid, you're becoming more basic. And vomiting, okay. Vomiting, we are throwing up the acid in our stomach, and the acid in our stomach is actually pretty acidic. Okay, it's like down at like 4 or 5 on the pH scale. Okay, it's pretty acidic. So if we are losing that acid from our stomach by vomiting, we are losing stomach acid, which is making us more basic. And remember, can we live in an acidic state or a basic state longer? Right? We will die faster in a basic state than we will in an acidic state. We can live in an acidic state much longer than we can in an alkalotic state or a basic state. Okay? So when you have somebody that's complaining of diarrhea, okay, it's not necessarily a life threat. They can live a little bit longer suffering from diarrhea than somebody that's been complaining of the fact that they've been vomiting for the past 4 or 5 days, right? Vomiting is a life threat, guys. They are becoming more basic. Okay, so how does the body actually sit there and adjust our acid-base balance? Okay, well, we have some buffer systems that kind of help us out. The main and fastest buffer system that we have is the blood itself. The blood reaches the brain faster than anything else, and the blood has chemoreceptors along with the brain in order to adjust the pH accordingly. Okay, we have our lungs. Our lungs do a great job at eliminating acid. However, the only acid that the lungs eliminate is CO2. Okay, there's no way of eliminating lactic acid or any other kind of acid that builds up in our body that the kidneys can. Okay, the kidneys are the slowest, okay, at converting. However, they are the most efficient, and that's because they are able to get rid of lactic acid for us, where the lungs only get rid of CO2 for us. Okay, so this is a very kind of famous formula that you guys are going to see throughout your EMS careers. And I'm not going to get too much into this. This is a little bit more advanced than I wanted to go with you guys, but I think this formula really kind of puts some stuff together for you as far as how the body eliminates the waste of the acids in our body and keeps us in that 7.35, 7.45 pH scale. Excuse me. So basically, the blood buffer system is the fastest. It works almost instantaneously. All right. However, it's not. It doesn't work long. It can be overwhelmed pretty quick with acid in the body. However, your blood has something that's called bicarbonate in it, and the bicarbonate actually kind of converts the acid into something called carbonic acid. When you guys are looking at this formula, the middle chemical equation there, the H2CO3, is the carbonic acid. And basically, you guys can see the arrows on how the carbonic acid can be changed into CO2 and H2O, or hydrogen and bicarb. Okay? And it's constantly going back and forth 24/7, 365 during your adjustments in pH. So if that carbonic acid, the H2CO3, if the body converts that into water and CO2, then the lungs is what the lungs is what dispels the CO2 from the body. Okay, it gets rid of the acid that way. However, if the carbonic acid is broken down into the H plus, which is the true acid in our body, known as the hydrogen ion, and bicarb, then that is when the kidneys kick in to pee out the hydrogen ion. Okay? So again, I'm not going to get too much into it, but this is just a picture for you guys to make you guys understand that the lungs only get rid of acid by blowing off the CO2, where the kidneys are the most efficient but the slowest, and they get rid of the hydrogen ions for us through our urine. The lung buffer system is the next system to work after the blood is overwhelmed. It regulates CO2, right? So we blow off CO2 or we hold on to CO2, depending on what our brain wants to do. This slide shows you how when the ventilatory rate goes up, we're blowing off too much CO2, which means our pH is going up, so that means we're becoming more basic. When our ventilatory rate goes down, we're increasing our CO2 because we're not blowing it off, so our pH drops, which means we are becoming more acidic. Okay, this is just another visual to kind of help you guys out. Now, I don't want you guys to get confused with this. This is if we are having problems with the ventilatory system. If for whatever reason we go into a hyper ventilation, or our respiratory rate's going up, our CO2 is going to drop. Now, the body's natural defense, when it comes down to it, ventilatory rates follow CO2. So if my CO2 goes up, my brain's going to increase my ventilatory rate at first in order to try to blow that CO2 off. And as my CO2 is dropping, my ventilatory rate is going to drop in order to retain the CO2. And then lastly, we have the kidney or the renal buffer system. Again, it takes the longest to work. However, it works very well. It is very efficient at removing acid from our body as long as we are staying hydrated, and it works off by getting rid of the true acid in our body, which are the hydrogen ions or that lactic acid buildup. Okay guys, we are done with anatomy and physiology, and that was definitely a crash course. Okay, again, these lectures are designed for us for EMS. Okay, specifically on how to recognize what's normal in the anatomy and physiology, because once we start getting into the certain disease processes, we're going to start talking about abnormal. All right, to focus your studies for this exam coming up. All right, I want you guys going over respiratory, cardiac, and neuro without a doubt. Okay, and then make sure that you guys kind of look back over shock and make sure that you guys understand how the body eliminates waste. Okay, if you guys are confused about anything, I suggest you go and look it up in the book. Make sure you read that section in your book. This is all out of chapter 6, with your human body or human anatomy and physiology chapter. Okay, listen to these lectures as much as you want. Come back to them. I'm going to leave these lectures open for the rest of the semester for you guys to use as a review. I hope you guys enjoyed these. Again, I try to keep these lectures fresh. Some of this material is pretty dry. It's pretty monotonous, but hopefully you guys have a decent grasp on what you guys need to study now as far as human anatomy and physiology.